Hi everyone, I'm Dr. Akhila, consultant fertility specialist, Sudha Hospital, Banjara Hills, Hyderabad. Today we are going to talk about the recent advances in fertility. So fertility has come a long way, and in the last 10 years there has been a lot of changes, a lot of advancements that have happened. From numerous protocols that are developed, we now have a personalized protocol that we can make according to the patient requirements. For people who have normal number of eggs, higher eggs, lower eggs, every protocol is different for every patient. We've also been able to decrease the complications of IVF with better injections, and we are now moving ahead towards single embryo transfer where we decrease the number of twin pregnancies or multiple pregnancies. We also have very good protocols to decrease ovarian hyperstimulation. Put together, all these are the multiple advancements that have been made over the last decade to make it more acceptable to the patient. The injections also are not as painful as what it was before. So these are some of the you know the changes that have happened. Now coming to the technology part of advances, one of the first things that has changed is testing of the embryo, that is the pre-genetic testing. So what we call as the PGT, we are able to test the embryo for aneuploidies, we are able to test the embryo for monogenic conditions, we are able to test the embryo for structural rearrangements. So this is called PGT, A, M, and SR. This is indicated in patients who have certain genetic conditions, hereditary disorders, also indicated in couples who've had many miscarriages, failed IVF cycles. These are some of the indications as to, when we do test an embryo in advanced maternal age. So these are some of the indications of doing pre-genetic testing of an embryo. Now the next is coming to ERA, endometrial receptive array, wherein we check the endometrium for its receptivity. The calculations that we make to do an embryo transfer, are those calculations right? And the time at which we transfer the embryo, is that time accurate, or do we need it a little before or after? This test is called as pre-genetic. This test is called as endometrial receptive array. Now, the other very important technology that has come up is that of time lapse, where in the embryos, when they are in culture, we're able to see how they multiply. So some of the details can be missed by a human eye, and these details can be caught by this time lapse, wherein we see the embryo multiplying on the day one, how is it on day two, day three, day four, and day five, how the division of cells is happening. Based on this time lapse technique, some of the artificial intelligence models have come up wherein we can select a good embryo for transfer. That is, normally what we do is we look at the embryo and morphologically, that is, we see how the embryo looks like. If it looks as expected, that embryo is supposed to be considered as a very good embryo. Now again, if we do a pre-genetic testing on this embryo, a euploid or a genetically normal embryo is chosen for transfer. Now whether this embryo will implant or no is something we cannot really tell, we need to wait and watch for it. But when it comes to using this timeline, time lapse imaging, and incorporating with artificial intelligence, we're able to choose an embryo that has a higher potential to implant. So this is still under development, but it's one of the very interesting advancements in IVF. Now, there's something called as microfluidics, which means how to select the best sperm. Now, we have sperms in millions. Now, which sperm is used to inject into the egg. We need only one egg, one sperm for each egg. So which is that one sperm in millions? So there's a technique called as microfluidics, where a sperm is put into a chamber and the chamber sorts it out. It tells us which is the best sperm, which is not a good sperm. Normally, a human checks based on how the sperm is looking, how its motility is. But now, this technology helps us select a better sperm in order to create a better embryo. And one of the other things is embryo glue, which has hyaluronidase, and as the name suggests, it helps in implantation of the embryo. And whether is it a must? Definitely not. It only means that maybe there is an added advantage that maybe embryo glue can help the embryo stick to the uterus, but it depends on um, whether the embryo actually implants or not. But this is another very important substance that we use nowadays, embryo glue. Now, the other thing is vitrification. Vitrification is rapid freezing of embryos. Now, when these embryos are created, we freeze them in minus degrees. And the survival of these embryos is very important the day we want to transfer the embryos. So, when we do vitrification, before it was a slow freezing, now it is rapid freezing that is done with vitrification. And vitrification has nearly about almost 100% survival rates for all the embryos. Um, Another very important technology is in vitro maturation, wherein the eggs are collected on day 3, day 4 of the cycle, wherein only about 2 or 3 days of injections are given, and the egg collection is done when the eggs are still immature, which means the woman is not spending a lot of time and money on injections. The number of injections are less, and we collect these immature eggs, culture them in the lab, make them mature. Once they're mature, it's like an IVF process wherein the egg and the sperm are mixed. So this is called as in vitro maturation, more so if IVF has failed or in women with PCO, in people who have high risk for complications, this IVM technology can be used. We do have babies who are born through this IVM technology, so it's not really experimental anymore. So these are some of the recent advances in IVF. Any questions, please? So egg freezing, we already spoke about vitrification. Egg freezing is definitely an option for women who want to postpone their fertility for any reason, be it career, be it because you don't want to get married quickly, or even used in women who are suffering with cancers, wherein we have to give chemotherapy, radiotherapy, or remove the ovary. Before all this can be done, they can freeze your eggs. That is definitely an option, and almost 90% success rates you have, that is when it comes to survival of these eggs once they are frozen. It almost reaches to even 100%, 90 to 100% success. So there is no difference between a frozen embryo transfer and a fresh embryo transfer. We only have to look at the hormone profiles if we are going through a fresh embryo transfer. The hormones needs to be checked because you've taken so many injections. The hormones are a little haywire. So that's the only, and the timing has to be matched when it's a fresh embryo transfer. Otherwise, the success rates are the same for fresh or frozen embryo transfer. Frozen embryo transfer gives you the opportunity or the window to plan yourself for an embryo transfer. There is no harm in freezing the embryos. The embryos can be frozen for a long time, maybe 5 years, and upon renewal, even longer. And the embryos are very healthy. There is no problem with that issue. The survival of the embryos after thawing, that is, after removing from the frozen state, is excellent, almost 100%. The reason being, vitrification that I've already explained about. So once you have conceived, you can't really lose weight because you can't do rigorous exercises, neither can you do follow a strict diet. So right now, now that you have conceived, follow a healthy lifestyle, healthy diet, and maybe a moderate exercise in terms of walking is something that you can incorporate in your lifestyle. Yes. So after two miscarriages, we definitely need to find out why you've had these miscarriages. Is there any autoimmune problem? Is there any genetic problem? It's something we need to look into. And the kind of medicines that are given for pregnancy support are different. Should you conceive naturally, please visit a specialist to be able to get those kind of medicines and injections. Otherwise, a battery of tests are done for to understand why you're having these recurrent miscarriages. The other thing that I already mentioned is pre-genetic testing of embryos to look for aneuploidies. Most of the miscarriages happen because the embryo that is formed, whether naturally or through IVF, is not genetically appropriate. So we do something called as pre-genetic testing on the embryo to look for these aneuploidies, and a euploid embryo is transferred. Euploid embryo would mean genetically normal embryo with respect to the number of chromosomes. So, two failed IVF definitely there is no guarantee that a third IVF you will definitely conceive, or you cannot even say that the third IVF is going to be similar to what has happened. So what we need to understand is what went wrong in these two IVFs, at what stage did you fail, to make corrections accordingly, incorporate PGT and ERA in your next IVF cycles, and it should be better. So once an embryo is implanted using ERA and pre-genetic testing is used, the success almost goes up to 70%. So for male fertility, like I've already mentioned, it depends on what the counts are and how the motility is. We do have, if it is azoospermia, we do have based on the hormone levels, can we increase the sperm count? If the counts are less by giving injections in the form of FSH and HCG. There is another very important technique called as TSA, which I didn't talk about, wherein the sperm is retrieved from the testes. It's called as testicular sperm aspiration. There is something called as micro TC, wherein we put in a microscope to look at the sperm in the seminiferous tubules and then take that sperm. These are some of the recent advances that are there, and the other one that of microfluidics I've already spoken about, wherein we send the sperm in a chamber. It's a small machine which sends in the chamber. The chamber sorts it out. It tells us which sperm is good, which sperm is not so good, and the good sperms are used to do IVF or ICSI. IVF is not painful. The procedures are are very, very short duration procedures, about 10 minutes, 15 minutes. Embryo transfer is not even done under anesthesia. The pickup is done under IV sedation, not even general anesthesia or spinal anesthesia. You can go back to work the next day. Of course, you need to take a few medicines and injections, but per se, none of this is painful. And as of now, we don't have any technique wherein an embryo pickup is done without a surgery. It's a very small procedure, rather. Of course, a lot of patients conceive in their first attempt. So it's a myth that you don't conceive in your first attempt and you need multiple cycles. It just depends on how well we are doing that cycle. If you have more number of eggs, more number of embryos are created, and you don't have to go through that pickup cycle all over again. We just do the transfer multiple times. And if one method has failed for any reason, we need to figure out why that method has failed and try to adapt another method to be able to succeed. So the new things is what we've already spoken about. The protocols are different. Every patient gets a different protocol based on the needs of the patient and how many eggs are there. Even for the sperm, depending on the sperm, we use better techniques to select the sperm, embryo creation, and the transfer protocols are also different. If there is a need, we do pre-genetic testing, we test the uterus also doing endometrial receptive array. If required, we may have to do a hysteroscopy, arthroscopy based on the needs of the patients. So these all put together, we now have an IVF success of about maybe 50 to 60%. That's quite a high success rate.